to the Core Stability Lecture. I am Dr. Tamara Heffron, Doctor of Physical Therapy and Board Certified Orthopedic Specialist. In this lecture, we will be going over multiple things we would like you to be able to assess, define, organize, and identify impairments in the core neuromuscular control, strength, and endurance. I want you to review your anatomy and your physiology related to the core, learn how to safely challenge the neuromuscular system and the musculoskeletal system to integrate contextual factors, and develop core exercises. We'll also go over some objective findings and how to test the core. So what is core stabilization? We hear that a lot. It's talked about a lot. It's performed a lot in therapeutic exercise and in personal training. So we really want a dynamic core stabilization training program to be the key component of all of our comprehensive rehab. So what that means is if someone comes in for a shoulder injury, you still should be looking at how they control their trunk and their hips, because all of that relates to stability of the extremities as well. We know that a really good core stabilization program will help improve dynamic postural control. So any transitions that someone goes through, sit to stand, supine to sit, any of that will be better because they actually have a core that comes to help them rather than inhibit them. We want to ensure appropriate muscle balance throughout all of this. So we'll talk a little bit about that as we move along in the lecture. So the core is defined as the Lumbopelvic Hip Complex. So this is a great picture. It shows you all of the musculature that attaches into the pelvis is included in our core. Our center of gravity is located in our core, and so that's really, if you think about where most of our movement stability comes from, is our ability to control our core. When we start to lose that control, we start to get wear and tear on our distal extremities, which can cause harm and surgeries and things like that, which we don't want. There's 29 muscle attachments into this complex, and it's really important that we, as movement therapists, analyze the length-tension relationship, because this really does ensure that the force couple relationships that exist within our core musculature are operating at that neuromuscular efficient level. It helps us optimize movement, and so we want to be able to ensure that we really do focus on this and this isn't neglected throughout our programming. What's the function? Well, we want a synergistic kinetic chain, right? So if you go to reach into a cupboard, so if you guys just do that with me, take your right hand and reach forward as far as you can. So what do you notice? You notice that not only do you have movement throughout your whole arm, but you also have movement through your core and stability. Now, if you sit in a really poor posture and you go to reach, you're going to notice that one, you have less range, and two, that you have more demand placed on your shoulder rather than that force being absorbed through your core. So we want a good core that can produce force. So if you think about like a tennis serve or something like that, we want it to reduce force. So I often think about if I'm going to step down onto something, I want to be able to absorb all of that force through the kinetic chain. So it's not as hard on my ankles or my knees or my hip or my back. And then we want that dynamic stability when an abnormal force comes. So can you guys think of an example of an abnormal force? So think about someone shopping, and it's a busy time of year, and think about the holidays. Someone's at the mall, someone gets bumped into. That's an abnormal force. We want someone to be able to adjust for that. Postural considerations. So this is where your 30-second snapshot comes in. And you're going to take a look at that, but then you're also going to start to look at how do they sit, how do they stand, those kind of postural considerations. This is going to help you dive in a little bit deeper to that length-tension relationship. So if we think about the hip flexor in relationship to the glutes, the hip flexors are too tight and they're in a shortened position, it's going to have that reciprocal inhibition of the glutes. Well, if our glutes are weak, then we start to absorb forces in places that we don't want, like our low back and our knees. And so something that we really need to come back to think about. Arthrokinematically, we want to make sure that during movement, so if you go to raise your arm up all the way, you should have movement through your thoracic spine to allow your shoulder full range of motion. Well, to do that, you have to have deceleration of your rectus abdominals, right? So that you don't just keep going into a back bend. So if you think we want optimal arthrokinematics, but that's maintained by a core stability and neuromotor control that allows that quality movement to happen. This is what we were talking about. We talk a lot about upper cross syndrome, but we also start to get like a lower cross syndrome. So really looking at this is if we have tight hip flexors, we start to get a longer and weaker abdominal. We get those weak glute max, and then those erector spinae in the back start to get tight as well. So again, we're going to try to balance those out to help someone maintain a good posture, but also be able to strengthen in the position that you want them to. We want them to optimize now. Once we have that really balanced out stability, we want someone to be able to use now that through acceleration, deceleration. Think about that even for the elderly, getting up and out of a chair, we want them to be able to accelerate and then decelerate so that they don't fall when they're going through that. Or you can think of any really athletic sport. So if you think about a swimmer getting ready to dive off the blocks, we want them to load to explode, right? So, but they have to have so much good dynamic control that makes them so much more effective and efficient. The transformational zone is extremely important, and oftentimes this is where someone is going to have that complaint of pain, right? So they might be able to do an initial part of the serve, but as they load and they go to switch into from that load now to that explosive power or that transfer of force, this is where we start to see a lot of times the ability to control that lumbopelvic hip complex starts to decrease. Well, and then what happens? So if I'm going into a really big extension type of activity, yet I don't have the ability of my core to stabilize me, I'm going to end up compressing into my lumbar spine. So I'll have now more bony contact than I would if I had had a really good strong stability of my core throughout that movement. We want to really pay attention to our neuromotor efficiencies, and of course, when we're looking at someone, we're looking at their deficiencies. So we're looking at the CNS and how that organizes the agonist, antagonist, the synergy muscles, along with the stabilizers and the neutralizers. The Turkish get-up is one of the best ones to look at to see how someone really organizes themselves. They have a really big open kinetic chain demand on the shoulder and thoracic complex. And then as they have to roll and get up, now we're looking at how do they manage through multiple planes of action what their core is doing. And then now when we throw in that they have to go into a kneeling to standing position, how do we work efficiently with our whole complex that's defined as our core? In rehab, we often focus on an isolated single plane of strength, or we spend all the time laying supine on a mat. Well, guys, that's not proprioceptive rich environment, so it's not really going to do as much as we would like it to. We want functional activities that are multi-plane, that someone has to really control that acceleration and stabilization. So I want you guys to think about, if you can try to think about maybe one or two other exercises that you've done or you've seen done that really do challenge the core in multiple planes. And then think about if that is a good goal for our patients to have, and most likely, hopefully the answer will be yes. We want to test our proprioceptors, right? We want to make sure that they can adapt to the activity and adapt to the demand that we're doing. We know that there's already going to be some muscle inhibition if we have some imbalances in the muscles. So we want to start by addressing that, but then start to reorganize the CNS so that we get that postural stability and strength. And then we can move into more force generating type of activities too. So inefficient. I'm sure we've all been part of the gym, right? And we've seen some pretty poor form. And what we see is that inability to respond to demands. So we look at this person doing a deadlift, right? And what do you guys think about that? What first thing that comes to mind when they're doing that? Well, one, it's so much weight and he's got such poor form, and now that lumbar spine is having to take on a lot more force than it should. And underneath that load, we're going to have a huge increase in intradiscal pressure, and then we're going to have a risk of injury. If you look at the woman doing the plank, now she's thinking she's doing a great thing, right? But then repetitive trauma over and over again, she's going to start to get some wear and tear, start to get some arthritis built up in the area. And she thinks she's doing a good thing, but we're not really getting there. You also see some compensatory actions. She's doing like a shoulder shrug, basically, to give herself stability. She can't control her core, so she's going into that hip dip. So really good things to pay attention for, and we'll go over more of those in lab. Key things for you guys to know is our global versus local musculature in the core. So global meaning those are our bigger dynamic muscles. They often work in a phasic type of phenomenon. So there are large torque producing muscles. What's important is if you think about that, you have to train that musculature in the way in which they were meant to be activated. So if you're thinking a large torque producing muscle, you should be thinking that it's got to be a larger excursion. There's got to be some force probably accompanied with that, or some velocity accompanied with that. The pelvis to the thoracic cage really basically provides the general trunk stabilization. So as we go through movement, you're going to start with the pelvis and the thoracic cage in a stable environment, but then you're going to progress where both of those parts are moving so that we can actually stress the system like it needs to be stressed. Our local muscles are really our postural muscles. Those are our tonic, where we need those more in an isometric type of phenomenon. There are smaller muscles, right? Our lumbar multifidi, those don't go multiple levels. So these all attach into the lumbar vertebrae. So something to remember and think about like that. They help us with our segmental stability and direct control of our segments during movement. So sometimes what you'll see is on a patient, you'll look on one side and their paraspinals are hypertrophied and really active and tonic on all the time, and the opposite side lacks that. They lack any activation at all. The person has trouble with that. Studies show that there's increased fatty deposits in that. So that's why sometimes we start with our more local training with our patients and our clients, is to make sure that they can get that neuromotor control before we start to get them in this dynamic, heavy loaded position. Let's not forget the hips. The hips are hugely important. This is one of the biggest things that's going to inhibit our activation of our core in the appropriate way. So addressing our psoas, making sure that that there's function in it. So is there strength in it? Is it just so tight that it's not even strong anymore? Can we get it into a lengthened position in a normal way without going into lumbar lordosis? You might have to do some of your manual techniques to reduce some of the tension into that psoas major. Remember, it's really that reciprocal inhibition starts to come to play. You'll see that glute max turn off. And then you'll see those deep erector spinae start to become tonic and really always on. Patients have a hard time turning them off because they're trying to give stability, because our rectus abdominis has become long and weak, and our glutes can't turn on because they're not in the correct position to turn on. So you guys really want to think about the glute testing, glute strengthening program for that. Synergistic dominance during hip extension means the hamstrings and superficial erector spinae are coming to play with that psoas, and it might alter that glute max function. So alternating hip rotation in that gait cycle, meaning that in gait cycle we won't get our transverse plane rotation. We'll see a lot more frontal plane into that because we can't actually even get through that hip extension to get there. The diaphragm and the pelvic floor. So a lot of us, those are inside, a little bit harder to recognize, but you guys, diaphragmatic breathing, diaphragm movement, those are really important because that's the roof of the core. So if the patient can't really figure out even how to activate their diaphragm in the appropriate way and get full activation of that, it's a great place to start. It's gentle. It can even act as a pumping action, helps with meditation, so it can calm the system down when there's pain present. The contraction of the diaphragm increases that intra-abdominal pressure, right? So it can help get stability that way too. When we have poor ventilation capabilities, we have that increased compressive force on the lumbar spine. So all things that we really don't want. Our pelvic floor is tricky. So it's hard to assess, and you have to go, have probably continue education courses outside of school. You'll get some entry-level discussion on that and work on that in some of your other coursework during your DPT program. But if it's something that you're really interested in, we recommend that you really look into that. If not, make sure that you understand that if there is pelvic floor dysfunction, so if there's pain with activation, if there's trouble with urination, if there's other things like that, and we'll talk more about that in some other classes, that you refer them out to a specialist that can help and maybe can be part of the rehab team so you can still keep your patient that way. Let's go. We're going to watch a few videos on some diaphragmatic breathing. Recommend that you guys watch it once and then go through it. See if you can do it on yourselves or do it on a partner so that you get some practice with it.
Okay, so we're going to go over diaphragmatic breathing. So you're going to have your patient place their hand on their stomach. Okay, yay! Okay, great. And then you're going to place your hand just kind of medial to their ASIS so that you can palpate their belly too. You're going to ask them to just take a deep breath in and just kind of see what happens. Okay, so you can kind of tell when Dr. H did that breath, there was a little bit more accessory muscle activation. Okay, so this time we're going to have her aim her breath for her belly, for her hand. Okay, so she's going to try to inflate her belly a little bit. One more time, deep breath. Good. And then relax. So in this position, her diaphragm isn't having to work against gravity. So in side lie, it's a little bit easier to perform.
Okay, here's the next one. This is, so side lie is probably one of the easiest ways to start, and then move to supine.
Great. Now we're going to go over diaphragmatic breathing. Okay, so now we're in hook lie. You're going to again have your patient just kind of put their hand lightly on their belly, and then you're going to ask them to take a deep breath and just kind of observe what happens. Okay, that wasn't that bad. But what you guys saw is her sternocleidomastoid turn on, her upper trap turn on, a lot of those accessory muscles trying to help inflate her lungs. We really want her to use her diaphragm, okay? So we're going to have her kind of just do what she can to relax her upper body, okay? We don't really want any movement up here. And then what I want you to do is kind of aim your breath for your belly, okay? So your hand should actually come up, okay? Go for it. Take another deep breath. Good. Sometimes if you ask your patients to breathe slowly and breathe in through their nose and then out through their mouth, sometimes that helps them direct their breath as well.
Okay. So what are our overall goals in rehab? Well, we know we really want to address whatever our patient has come in for, right? So their main complaint, we're going to make sure we keep their long-term and their short-term goals at the forefront of our programming. With that, though, we should always keep in mind that dynamic postural control is hugely important for the stability of our limbs. So we want to do that through not only isolated maybe movements, but then coming into that more integrated, synergistic movement patterns that we know that our patients need to be able to perform. We want it to increase neuromotor efficiency. So thinking about how to program that, you should have some integration of your tonic muscles, but then also thinking about I need to challenge my phasic muscles in a bigger, higher velocity power type of phenomenon. Assessment. There's a lot of assessment tools out there, and we won't get to all of them. This is just to kind of give you a brief introduction to it. But assessment-wise, we're going to always start with your snapshot of your posture. You're going to look at range of motion, so we recommend that you look at your thoracolumbar range of motion and your hip range of motion. Look at lower extremity functioning, because we know the hip is extremely important for that. And then specific to the core, there are different categories we can talk about. So we can talk about endurance, neuromotor control, strength, and power. You can also just come to think about, you guys, that your exercise, and we've said this in other lectures, is that your test is your treatment and your treatment is your test. So let's say that we don't go over a test today, but someone comes in and they tell you that they are a snowboarder, right? And so they're doing a lot of what we would consider maybe frontal plane mobility. And so you want to look at their ability to control their trunk as they do like a 180 jump. So you might look at that and you might think that you're just looking at them jump, but you're probably assessing how they handle their core throughout that. So it's okay to not necessarily use these tests as your one and only, but know that multiple functional movements, you're actually looking at how someone controls that lumbopelvic hip complex. So a core test, this is in the literature, there's the prone bridge test, which is really our plank, right? Lateral bridges, so a side plank. Torso flexor, so that's more like an abdominal curl. Torso extensor would be like a Superman type of phenomenon. Looking at how someone controls as they go through a single leg squat, or even just a regular squat, would be a great idea. So here's an example of side plank. Not only just maybe the test of it, but then some progression ideas for you.
We're going to demonstrate a side plank progression. There we go. So first you're going to do just some up downs, especially if your patient can't do an isometric hold. Now we're going to do an isometric hold, and then you can progress to some lower extremity and upper extremity drivers. So here's some hip flexion. You can do hip abduction. You can do hip flexion and hip extension. You can do some jacks. You can do clockwise and counterclockwise circles. Yeah. You can do a lot of different variations, so be creative.
Okay. Yeah, so making sure you kind of have an idea of how you might progress through that, but some of us are going to even neglect this for some of our elderly patients when this would be a phenomenal exercise to do, because even in a regular plank, you're going to see patients with really poor position and posture, but a side plank almost forces that opening of that anterior chain and can really help someone out with that. Okay, so you guys are going to look in your book and you're going to look at the abdominal blood pressure test that will test the core. We will not really use it in practice, and it's not really used in practice, but it's used in the literature quite a bit to test the transverse abdominis. You can also use leg lowering. So you can look, and I would suggest that if you feel like someone has a weak core, you just start with one leg and watch the stability of the pelvis. Or you can look at the lowering of both legs and watch what happens as someone lowers into their rectus abdominis, but then also through their lumbar region. So do they go into a significant lumbar lordosis and have the inability to control leg lowering? So core strength and test, we can now do that straight leg test with velocity. So I'm sure you guys have seen that where a partner is holding onto their other partner's ankles and then someone is pushing their legs down. Well, now we're testing probably more power. We would train for that. We wouldn't do high reps with that. We do lower reps with higher rate of velocity. Another great test and exercise is the overhead medicine ball jump and throw. What a great eccentric control requirement for your core. So you're going to see a modified variation of that here.
Dr. H is doing a few lifts and chops with a medicine ball to increase her core activation. We're also going to do a few medicine ball slams. Good. Remember, you don't have to stay in one plane. It's really good to change the location. And then we're going to do an explosive ball toss overhead.
Okay, so guidelines. We want it to be systematic, progressive, and functional. One of the main things we want you guys to take away is we want it to be proprioceptively rich, meaning that we want to test it in different ranges. We want to test it in different speeds, different loads, then adding in the upper and the lower extremity to really challenge the patient. Please start with what the most the patient can do and then start to progress from there. So sometimes you're going to have to do some different testing to find out what that is. So in the following slides, we're going to go over 4 different exercises. We're going to start with just a basic abdominal bracing or draw-in with added resistance, and then we'll start to progress out of that so you guys can see a little bit.
Okay, now we're going to do the abdominal draw-in with the addition of isometric hip A, B, and A deduction. Typically, we'll start out doing that with manual resistance. So what I'm going to ask Dr. H to do is just hold your legs right here. Okay. Don't let me pull them apart. Okay. Good job. Maintain that draw-in. Good. And then you're going to relax, and now you're going to push out. Don't let me move you. Okay. Good job. Maintain that draw-in. Keep your tummy tight. Okay. Good. We're going to do one more time. Good. Awesome. And then after they get pretty good at that and they understand what effort you want them to use, you can give them equipment so they can do it at home. So they can do a band around their legs, and then they can also just have a ball in between their knees to alternate between a deduction and a abduction.
Okay, so here's now the next step. You might add into that, or you might do both as part of a circuit.
We're going to go over the abdominal draw-in with the addition of perturbations to increase the activation of the transverse abdominis, okay? Great. So we've already done the draw-in. You're going to have your patient kind of set their belly. Good, we're in a neutral spine, so you're making sure they're not in that posterior pelvic tilt. And you're going to have your patient just hold your arms there. Don't let me move you, okay?
Real strong.
Oh gosh. Good, don't let me move you. Okay. So I'm just going to give her, initially we're going to go up and down. Okay, now I'm going to squeeze in. Good, I'm going to pull out. Good. Good, and then, yeah.
So at home, you guys need to try it and see which direction you feel the most.
Great.
So guys, on this might be a great exercise for someone coming in for shoulder rehab because you're working on some proprioceptive rich exercises, rhythmic stabilization for their shoulder, but you're also going to require them to activate their core to enhance their stability. Okay, now we're going to move to standing, but I'm still supported. So you notice that I still have back support. And so I don't maybe have to control as much of my core because I do have that stability, yet I'm still challenging myself.
In this video, we're going to demonstrate an abdominal draw-in in a supported position against a wall. So right now, we're doing a draw-in while we're doing a mini wall sit in addition to upper extremity drivers.
Good. Okay, and then now here's this. So tall kneeling is a wonderful position for your patients to be in because it really does open up. We talked about the psoas. So it helps activate that, and so the psoas isn't going to inhibit that.
Drawing with a row. We were thinking about doing a lat pull, but the resistance is pretty heavy.
Oh, whatever.
So we shorten the oh! So you can do a row, or you can do a lat pull for your patients to increase their activation of their transverse abdominis, their multifidi. A kneeling position also really benefits lengthening their hip flexors and activating their glutes.
So what are you going to vary? Well, that's the awesome thing about a good core program and really a good program in general. We can start with planes of motion. So, you might start with where you're doing more of isometric holds for your core, but then you're going to start to add in, we're going to work in the frontal plane. So you're going to do a side plank. And then Once we start to see really good stability with sagittal and frontal plane, then we can start to add in transverse plane, which is really going to start to add in that demand, increase the demand. All these are other ways in which you can do that, and you guys will start to play around with that. There's not necessarily a rhyme or a reason between plane of motion, range of motion, except you want to watch your patient really closely when in that transformational zone, okay? Then lastly, once you start to see that really good dynamic stability in an isometric hold, then you're going to start to allow that trunk to move through planes, and your patients will be able to demonstrate more of that. Kind of like we saw with the overhead medicine ball throw. Now moving into a bigger range of motion, I'm adding speed to that. I'm going from a squat to a full extended position. So really good with that way. So here's a great stir the pot. I'm having to do an ISO hold.
We're practicing an exercise called stir the pot. So you're gonna maintain a plank with your elbows on the ball. You're gonna have your patient go clockwise and then counterclockwise.
So you guys, if you notice, if you slow down the video a little bit, I actually have a little bit of trouble because I have really tight hip flexors. So I'm probably not getting into the hip position that I need. Is probably what's making it extra hard for me to perform that. So take a look. You guys try it out. We want you to try all these exercises out. Okay, so this is we're starting to add in.
Demonstrate a dynamic bear crawl. So you're going to do alternate upper extremity and lower extremity movements, maintaining that transverse abdominis contraction, trying to kind of keep your belly really stiff.
So wrong is this. We're not doing spider crawls, right? So you're just doing your strict bear crawls.
So with some of those, you guys, you can, again, get pretty creative when you're looking at those, but watch for someone to really go into increased lordosis, or watch for those compensations to make sure they're not doing that. This is a nice way to think about things, right? This would be any progression that you have with your Therex. You want to see a slowed control movement, then you might move to fast. Simple to complex. So meaning simple is I'm against the wall doing more of a PNF X pattern, but now the complexity, I'm going to move to that really good iso hold bracing of my core into that bear crawl, much more complex and challenging for me to process through. Stable to unstable, so we saw I might do a plank, and then now I'm going to progress that to the stir the pot. So keep these progressions in mind as you go about your writing your exercise programming for your patients. Okay, so here's a great one. We often forget that we need to change the position up and really address where our patients are as far as maybe they're having trouble and they get a lot of pain in seated. Well, don't forget to do some core stabilization exercises in seated then. Pay attention to what they're telling you and also what their posture looks like.
Great, so in this position, we're getting core activation in the transverse plane as we try to maintain an isometric hold with neutral
Don't laugh
spine,
until you try it, people.
neutral spine on an uneven surface.
Yeah, Dr. Summer, she's so mean to me. So, okay, then here's an example of plank progression. You can do planks in multiple ways. We just want to give you guys a few ideas of a few progressions.
Dr. H is demonstrating some shoulder taps, maintaining a neutral spine. A progression would be the addition of a leg driver, so we're getting some spinal movement in the transverse and the sagittal plane. You can also do some hip dips, so larger movement spinal motion in the transverse plane. And we can also progress to some big arm drivers. So we're going all the way to end range, nice large rotations.
So that's what we were talking about with planes, right? So we started in an isometric hold with just some shoulder taps, the lower extremity driver added in frontal plane, and maybe just a little bit of transverse plane. And then when we go to more of our rotations, now we're asking that whole complex to really stabilize as we move through. Okay, guys, just a few more slides, and we'll move pretty quickly through these. When we think about postural considerations, this is just a reminder for you. This was a kind of a repeat slide from the beginning, but now that we watched that, thinking about that normal length tension relationship, our force couples, so what we want working, and then optimize that arthrokinematics for your patients. Look at if we're preventing our core from working because of those muscular imbalances, and maybe you have to design a really good flexibility, mobility program. And then try not to give something too hard because you're going to see some of those compensations that come through from that. If your muscle tightness is significant impact like kinetic chain, it's going to make that core weak and not really work as well. So keep coming back to that. Make sure your neuromotor control is there. So we want to start with that strong, stable core with that supported base of environment, and then move to progress out of a supported base and open with still isometric holds, then add in more trunk movement on body, then add some force into that. Optimize your core function will very, very positively affect your peripheral joints and protect them as we ask it to do a lot of the demands of life. Our core stabilizing program, one of the main things I want you guys to take away when you look at your programming is how much time under tension do you have? So you might have a lot of different exercises, but your time under tension for your core is the majority of the time. And maybe your patient has said, I can't go past 30 minutes without my back hurting when I'm seated at work or when I go for a walk. And now because you've been training for 30 minutes in that time under tension with multiple exercises, even if you think about lifting our big global muscles, that's time under tension for our core, that you're going to see so much better stabilization. Our patient education is key, so just help them visualize, help them understand how to activate their multifidi and their TA, and then keep that breath work as part of your routine. Help your patient really identify, are they holding their breath? Do they not breathe the correct way? And get some activation with that. And you guys just have fun with it. This is one of the best, most fun ways to get your patient involved and love exercising.